So good afternoon everybody. So following on from Sammy, I've really spent the last 13 years really focusing on patients living with and beyond cancer and really trying to be an extra voice for that patient group, if I'm honest. We know that there's lots of late effects from treatment, be that be surgery, radiotherapy, some of the other systemic treatments, but we also know it's quite complex and a lot of patients are living with and beyond cancer with undiagnosed late effects from treatment, under-recognised and often ignored, and that's what we've been seeing over these past years. So I really vowed that I would make this my mission really in my career to set up these late effects services and ensure that most patients can get access to them. We're quite lucky. Mine was the first. I set mine up back in 2013 and since then we've set up 18 specific for radiotherapy. There's only 2 that specifically concentrate on head and neck. But many services do all tumour sites, which is mine does. Most of them are radiographer-led, like myself, although we also have lots of other disciplines and allied health professionals now that come in and work together for the best of that patient. But we need to make sure that these late effects services are a real integral part now of our oncology pathways because we're curing so many patients and so many patients are living with and beyond, but at what cost? So the thing about late effects management is it's not just about giving a treatment or providing a management for that late effect. We've got to be educating patients on the potential for these late effects. And I think before that's often we very much talk about the acute toxicity, so the side effects that you're going to get on treatment, but what about 10, 15 years down the line when sometimes some of these late effects can develop? We need to have late effects expertise because until I really started, nobody really focused on what I deal with now. So we've never really put research into this area and that's something that we're trying to move forward with. So a lot of it around late effects is acknowledging how patients are and actually helping to provide self-supported management. We won't just want to give you a set of exercises and they go off you go do these exercises. We need to explain why is it important that you do these and keep checking in because a lot of these exercises may be for life. So we need to be empowering patients to really take management and responsibility for their effects, but making sure that the medical teams are providing that support from the onset. So my service then, I've seen 2,308 patients to date. That's new patients struggling with the late effects of treatment. Of them, over 1,000 have been head and neck patients. So that's where I've really started to focus, particularly over the past 9 years, about why is it that head and neck patients have got the highest unmet need after treatment. And when I look back, there was 30 salivary gland patients that have been through, which doesn't sound like a lot, but as we know it's a very rare cancer, that is still quite a prevalent number. So what I vowed to do was to do some research into the area, really start to look at new novel treatments, what are they using in other long-term conditions that we can bring in, and also what is the best practice. So the area that I've really focused on is, because I'm a therapeutic radiographer, my expertise is in radiotherapy, is why do patients get these late effects from radiotherapy? And that's because of this radiation-induced fibrosis. So it's a progressive sclerotic disorder that only affects the area where you had the treatment. But for some patients, it's progressive. It's totally unavoidable. So yes, we can do different treatments, but even with protons, we still get these late effects, and we're seeing that. The problem with it is, like I say, it's progressive, but it might not start till 10, 15 years down the line. So our longest patient out of treatment is 42 years. And I've spoken to somebody today who's 40 years out of treatment and has just started to get some treatment for her fibrosis, which has been absolutely fantastic. The problem we have with late effects is, like I said, we present to GPs many years down the line. They think there's nothing that can be done. Or even surgeons will say, oh, that'll be that radiotherapy that you had. Well, that's not acceptable in my mind. Even if there's nothing that we can do, we should be explaining to a patient why they've been left like they had. And let's have a look at what other things we might be able to do to help. The problem is there's been no guidelines for it. So myself and a number of, it's about 30 clinicians now have got together to try and set up a best practice guidance. And that's the work we'll be doing with Salivary Gland UK as well, to really try and do what can we do if you haven't got access to a speech and language therapist? What's the bare minimum that a GP could do to help that patient out? Because not everybody has access to all these specialists. And we also know that we need to be identifying early. So what can we do earlier on in the pathway to educate patients about these late effects? And what can you do to give yourself the best chance of maintaining your function? So this is what I do very much. So like I say, we're doing some research into fibrosis, why it happens, what treatments can help. But I use a lot of novel treatments, what they're using in other areas. And this is where I found the photobiomodulation or low-level laser or red light therapy. Nobody believed it'd work. I've been laughed out of many of MDTs, but until we've proven the benefits, and we've got lots of clinical patients now who've had such an amazing response from it, that I've now got to go and do a PhD to prove it, which is a little bit daunting. But I look at all sorts. I use special collars that do a myofascial release. I use scar ones, anything that I think is safe to use. I've run it by my oncologist and they say just get on with it. So what I want to just show here is, and the reason why I put the top 3 tumour sites, because we do know that not everybody has a salivary gland cancer in the head and neck area, is that these are the main late effects that we see in our service on a day-to-day basis. All the ones that I've highlighted in yellow is what the photobiomodulation therapy has helped with. So things that we never even thought it would help with. So dry mouth, I never expected it to help with that. We've got patients now that have changed really no problem at all. But that's how much the difference that this is making on a clinical level. So just a bit to show you here, there's one patient, I know this is a Hodgkin's lymphoma patient, so that's a patient where we treated the whole of this area. This is our 42 years out of treatment. Been suffering this radiation-induced fibrosis. She got drop-dead syndrome, she couldn't hold her head up, severe pain. Before PBM, you can see there, so dysphagia, so difficulty in swallowing. Cervical dystonia is where you get these terrible pain spasms up your neck. Xerostomia is the dry mouth. Within 4 weeks of being on the PBM, all of those had improved. Absolutely phenomenal that she'd lived like that for actually 38 years. So hers started 4 years after radiotherapy had ended. And my famous patient testimonials, and I'm sorry if you've heard this before, but I just thought I'd let you know that this morning had my first cup of tea in almost 4 years. Phenomenal. And I cannot begin to explain how hard it is to live with the post-treatment. I cannot eat normal food, I have no saliva, I can't turn my neck, which is constantly painful. The last 6 weeks have been an unbelievable change to my life. This is the first time I've had any relief, it's like a miracle. And that is why I will fight for this treatment until everybody can get hold of it, if I'm honest. So now what? Well, this is it, the research. So we want to work out like what protocols should we use in, how do we get it out there to patients, what's the cost benefit. That's the hard thing with late effects because we are making savings. A lady the other week, 13 years down the line, now doesn't have a feeding tube anymore, but it's trying to prove them cost savings, which is quite difficult. We also want to collaborate with other intensive therapies, so speech and language therapy and the physios and the lymphedema teams as to how this can come together and be a real programme for this radiation-induced fibrosis. And we need to be educating and regulating its use as well. And I think that's me, but really just to say that, I think it is providing another tool in our toolkit, but I also believe that every patient should have access to these late effects services, and that's something that I will continue to campaign for.